Welcome, everyone. We will just take a moment to let everyone arrive before we officially kick off. We're glad you're all here. We'll just take another minute. Okay, and it is just about the top of the hour, so let's get going. Welcome, everyone, to today's Schwartz Center Compassion in Action webinar, The Artificial Intelligence Revolution in Healthcare, Opportunity or Threat. Thank you for joining us. I'm Julie Collier, Senior Director of Programs here at the Schwartz Center. As many of you know, we are a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. Our vision at the Schwartz Center is that everyone who provides and receives healthcare experiences compassion. Before we begin, I'd like to share a few details about what you can expect. Please note that the program will last 60 minutes with a panel discussion for the first 40 or 45 minutes, followed by some time for questions. Feel free to enter your questions in the Q&A pane throughout the discussion. I'd also like to acknowledge with gratitude that this Compassion in Action webinar series has been funded in part by a generous donation made in memory of Julian and Eunice Cohen. With that, I'll hand it over to Dr. Beth Lown, Associate Professor of Medicine at Harvard Medical School and Chief Medical Officer of the Schwartz Center for Compassionate Healthcare. And I know she's excited to get this conversation started.
Thank you, Julie. Welcome, everybody. Thank you for joining us. I'm really excited to offer this webinar to our community. Artificial intelligence is here to stay. It's going to affect all of us in our everyday lives and in our workplaces. I think very few of us, though, myself included, have a really solid sense of what AI could do to improve our care for patients and our own ease of work. So our panelists today will help us understand this rapidly evolving field. Today, we're joined by our moderator, Karl Swanson, MD, co-founder and head of data science at Quench, which is a physician-engineered generative AI company, and panelists, Dr. Michael Lesh, CEO and founder of Quench. Both Michael and Karl are on faculty at the University of California, San Francisco. Also joined by Dr. Ashwin Nayak, clinical assistant professor of medicine at Stanford University, and Dr. Vivek Rudrapatna, a gastroenterologist and assistant professor, also at University of California in San Francisco. So I'm excited to turn this over to you, and we'll get the webinar going. Karl, take it away.
Great. Thank you so much, Beth. Okay. So this is just a quick outline of what we'll be discussing. We already went through the speaker introductions and disclosures. I will give a brief high-level overview of what is AI and some of the challenges, the risks involved with using artificial intelligence. From there, I'll pass it over to Ashwin, who will discuss some use cases and applications of artificial intelligence. Then we'll pass over to Vivek, who will talk about AI for compassionate care. And then finally, Michael will talk about AI innovation and how to make a product with AI. So first, we're going through just what is AI and specifically what is machine learning, what are large language models, and kind of how do large language models work. So whenever I think about machine learning, I like to think of it in terms of use cases. And what exactly would you use machine learning for? So if we were to think about the game rock, paper, scissors, it's pretty simple. There's only a small set of rules. Rock beats scissors, scissors beats paper, and paper beats rock. But if you wanted to develop a system where you could recognize any image of a hand and determine whether that was a rock, paper, or scissors, and then implement the rules of the game into that system, it would be a much more complex task, especially in terms of computer programming. So traditionally in software, what happens is a programmer thinks of all the different rules that you need to create a piece of software. After they're done doing that, then they take some inputs that goes through the program and it creates some results. Machine learning is somewhat similar to this, but instead of trying to think of all the rules, so for example, in our rock, paper, scissors game, there would be far too many rules to think of. So what you do is you take these similar types of inputs, you pass it to a machine learning program, it learns the rules for you, and then it similarly produces results. But the program can update the rules itself after seeing many, many examples of things. So basically, you can think of machine learning as appropriate to use when there are a lot of rules about a specific task you want to do. We've all probably heard of the term large language model or ChatGPT. And all that is a very specific type of machine learning model. And it has a task to predict words in a given sequence of other words. And the specific type of machine learning model that these large language models are called deep neural networks. And there's a specific flavor of a deep neural network called a transformer. Deep neural nets were modeled after how brains function, and that includes neurons. And if we remember back to like neurobiology, neurons can take in a set of inputs. And if it reaches a certain threshold to fire, it will fire and then connect to another neuron and so on and so forth. And so that's kind of how neural networks work in general. You can see an image of what a neural network could be for recognizing the number 7. So these pixel values would be passed to each one of these little nodes here. And if the node activates, it will fire and hit other nodes, and eventually it will reach this final terminal layer of the neural network and output the number 7. Some earlier versions of machine learning were things that helped predict fitting a line to a graph. So we've come a long way from the earlier machine learning models to where we are today. So that is a very high-level overview of what is machine learning and what are large language models. And you'll probably hear things about some challenges and biases associated with using these large language models. And we'll talk through some of those things now. So probably the biggest buzz term around specific failure modes of large language models are something called hallucinations. And we can see an example over here of what a hallucination is, which is, how many countries begin with the letter Y. And it gives, kind of close to a good answer, but you can see that Yemen, that is correct, but the other 2 examples actually start with the letter Z. So a hallucination is simply just a collection of words that the model outputs that represent a confident sounding factual answer, but it's actually incorrect. It's not factually correct. And so that is what a hallucination is. And there are methods to drive down hallucination rates, but this is one of the more common failure modes that you'll see with large language models. Some other things that people are concerned about with using these models specifically is bias. Since machine learning learns from data, if there's bias within the data, you can actually bake that bias into the machine learning model and worsen bias in general. So that is something we always have to be aware for, and we look through our data sets to try to mitigate that risk. Bias can lead to a lot of unfortunate outcomes, in terms of treatment and discrimination against folks. It results in loss of trust of technology and can have pretty severe consequences, especially in high stakes use cases like healthcare. An example of this is, in hiring algorithms, for example, if a company uses a machine learning algorithm to screen candidates, and in the data sets that, there's a lot of male candidates, it may associate that, men are the candidates that they want to select for, but really that's just what the data set had in it. and that was a bias data set from the get-go. And so that would propagate that bias every time that machine learning model is used. There's also a lot of concern around energy consumption. These models are very expensive to train, both in dollars and in power. And this in particular, just for perspective, and this is kind of shocking to me, the carbon that was emitted to train GPT-4 was the equivalent of powering around 1,300 homes for a single year. Again, as our training of these models has matured, we're seeing that energy consumption can be reduced, but is certainly still an area of active research and something that we need to consider going forward. Even though we're driving down the cost of training a single model, we're training many, many more models in general nowadays. So I'm going to turn it over to Ashwin at this point.
All right. Thanks, Karl. Thanks for that really awesome overview of AI and LLMs. And now hopefully everyone has kind of a general understanding of how language models work and some of the failure modes that he went over. So what I want to do is I want to take some time to talk about some of the really exciting and promising applications of AI and large language models that you can see today. I'm sure most of you have seen that there's been a ton of research over the last couple of years. You've probably read headlines that say things like ChatGPT can outdiagnose a clinician, or can write a discharge summary better than a doctor can, or can respond to in-basket messages. It's all very exciting, but it can be a little bit overwhelming and hard to kind of understand what is real, what is maybe hype, how to organize all these things in your mind. So what I want to go over is some really innovative examples of kind of concepts or solutions that have really been proven out in research and actually translated from kind of bench to bedside, so to speak, into industry, so outside of the confines of academia. And what I'm going to start with here is just a little bit of a conceptual framework to help you organize some of these concepts in your mind. This is what I use, and I find it to be very helpful. So essentially breaking down these applications of AI on two axes. So on the x-axis here, the horizontal axis, you see on the left side, you have patient-facing applications of AI and language models. And then on the right-hand side, you have clinician-facing. And then the y-axis, you see non-clinical at the bottom, clinical at the top. And when I say non-clinical and clinical, I'm talking about the specific AI component of the solution. What is the AI doing? And if the AI is doing something that's close to clinical decision-making, especially if it's autonomous, then it's going to be much higher on this axis here. Next. So we'll start in this bottom right quadrant here. So these are non-clinical things that a clinician would be doing. And so things like revenue cycle management, prior authorization, medical coding, workflow, aspects of workflow. A lot of the things in this bucket you would think of as kind of the back office operations of a health system. A health system might employ a pretty significant labor force to do a lot of these things, but then the clinician would also be kind of looped in to help with a lot of these things. For those of you who are clinicians who have done a prior auth before, you know how long and sometimes frustrating it can be with all the paperwork going back and forth between the provider's office and the insurance company or the payer, and then ultimately getting an approval or a denial, and then kind of have to rinse and repeat. So a lot of companies have kind of recognized that this is a huge pain point, have recognized that there's a lot of manual steps in that process that perhaps could be automated with AI. Next. And next again. Yeah, perfect. And then moving to the bottom left quadrant, now we're looking at still non-clinical things, but tools that a patient might use. So scheduling, financial assistance, benefits navigation, care navigation. So essentially things in this bucket, I would think of as tools that help the patient kind of navigate the complex healthcare ecosystem, right? Whether it's kind of the broad insurance landscape, whether it's kind of an explanation of benefits or a hospital bill, whether it's just something as simple as scheduling an appointment. These are all great areas for AI to help the patient out and kind of cut down on some of the manual effort on the health system side. Next. So top right, so here we're getting into actual clinical applications where the AI is doing something clinical, but it's clinician facing. So a doctor or a nurse or a pharmacist using AI to help do something. Starting with analytics. When I think about analytics, I think of how can we use AI to really leverage this kind of treasure trove of data that we have in the electronic health record that's growing every day to answer, really valuable questions, to, improve the quality of our population health, to do, targeted risk assessments and targeted interventions. All that kind of falls under the analytics umbrella. Documentation, I think of just the huge burden that documentation has on our providers today. I think of it as a big contributor to burnout. Lots of time spent on finishing up notes. You have a really long, busy clinic day. You come home, you spend hours finishing your notes. That is a very clear area of opportunity for AI to come in and do a lot of automation there. And then moving to diagnostics, clinical decision support, this is where we ask the question, can AI actually help us diagnose a patient more effectively? Can AI actually help us manage a patient more effectively? Clinical decision support is not a novel term or category by any means. In fact, this is kind of a very baked-in concept, baked into like the informatics curriculum and literature. The kind of simplest and maybe one of the earlier forms of clinical decision support is essentially an alert, those alerts you see in your electronic health record, right? So if you're ordering a medication and maybe that medication is on the allergy list of a patient, you'll get a little alert that says, don't order this, the patient's allergic. That's essentially a simple rule, a simple form of clinical decision support. You can imagine how a language model that has the capacity to learn and kind of mine all the data into the EHR could potentially provide a lot more support, a much higher level of support than that. Next. Next one more time. And then, yeah, moving to the top left of the quadrant, now we're getting into patient-facing clinical applications. So for example, companion AI. So think of like a chatbot that talks to a patient, that counsels them on dietary advice, nutrition, lifestyle management, that kind of stuff, maybe even a little bit of therapy. Triage and intake, think of a chatbot that talks to a patient and collects symptoms before an upcoming visit, or does just normal intake questionnaires. Again, a lot of this stuff is manually being done by medical assistants or nurses, or in the hospital or in the office by the doctor or the clinician. And then lastly, I have AI-enabled care, and that's where we get into AI that's not just being used to collect information from the patient, but also to potentially deliver instructions or an intervention to the patient in potentially some form with some level of autonomy. And if that makes you a little bit nervous, that's, it should, because I think what you're touching on is, next slide. Yeah, let me go back one, perfect. Yeah, so what you're touching on is that, this top left category, I would think of that as the highest risk, right? So we're talking about things that are patient-facing, that actually do clinical things. High bar for safety, high bar for implementation, whereas things in the bottom right are a little bit lower risk because they're not actually doing clinical things and they're not touching patients directly. Next slide. One more. Okay, so now same framework. I'm going to just walk through a few specific examples. Next slide. Okay, so bottom right, tons of companies doing kind of these back office operations. Next. First one I want to highlight is Cohere Health. Cohere Health is trying to automate the prior authorization process. All right, so how do they do this? They do this by first digitizing the whole process, so no more manual kind of paperwork filling out and kind of sending it over to the insurance company. They kind of integrate with the provider, and then they also integrate with the insurance company, ingest all of those insurance company policies so they know the rules of what gets covered and when it gets covered and what shouldn't be covered. So that way, when a claim comes in from the provider, they can use AI to kind of match the claim and figure out automatically whether it should be approved or denied. And as you can imagine, this is something that leads to much quicker approvals or denials. And it actually, according to them, leads to a decrease in denial rate. And the reason being is that since the AI has knowledge of kind of what should be approved and what shouldn't be, because it has access to the insurance company's policies, it's able to kind of preemptively tell the provider what they should include in a claim. Because oftentimes you submit a claim and then you get a denial because you haven't included a specific piece of information that maybe you didn't know you had to include. But here, they're kind of telling you to do that beforehand. So just one example of how AI can kind of drastically, improve efficiency and improve something concrete like the percentage of approvals versus denials. Next. And then moving to the bottom left quadrant, here we're looking at, again, patient-facing, but non-clinical. Next. company I want to highlight is Syllable AI. So they're mostly involved in scheduling, among other things. If you think about scheduling, how it happens now, most health systems, it's a call center. You call in and you talk to a human, and they have access to a schedule, and then they get you into the next clinic appointment in the cardiology clinic, for example. Some places have apps, but even the apps have kind of limited, they have constraints on what you can or can't schedule. Stillable AI is essentially an AI call center where you can kind of replace most of that human component. Patients still call into a call center, they still get a phone number, but instead they're talking to an AI agent. And that agent can help them schedule appointments, refill their medications, and among a few other things, even get them in contact with the right kind of doctor's clinics. Next slide. Now moving to the top right. So now we're talking about clinical applications of AI that a doctor or a pharmacist or a nurse would use. Next slide. I want to highlight this big group here. So Abridge, Ambien, Suki, Regard, et cetera. This group of companies is involved in documentation automation. And of all of the different categories here that I'm talking about, this is the most mature application of LLMs or generative AI in healthcare. However, mature is definitely in quotes here because there really truly is no mature application right now that is, enterprise-wide in production, widely. But of all the different use cases, this one definitely has the most maturity to it. And it makes sense because documentation automation, one, it's a huge pain point like I had discussed previously. And two, it is something that AI could be particularly good at. And so a lot of these companies, what they have is they have these solutions that will listen in on a patient-provider visit, and then based on that conversation, automatically create a note. And then the provider can just edit it slightly and kind of submit it and be done. They don't have to spend kind of half an hour writing a note. A lot of the companies in this space actually kind of bleed into the bottom right quadrant. Because after creating the note, a lot of times they will take care of the billing associated with the notes. They're getting into the revenue cycle management aspect of it as well. Next. Another company I want to highlight in this space is Atropos Health. So this company is an example of kind of a good example of analytics. So what they've done is they've plugged into the electronic health record, and their AI is able to help clinicians answer very interesting and specific questions about their patients. For example, say you have a patient with a rare disease, maybe they're on a equally rare kind of treatment, and you're wondering, what's the prognosis of this patient? What are the possible treatment options that I have available for me? You could go to the literature, you could try to find an applicable clinical trial, or you could use a tool like Atropos Health to ask that same question. And what Atropos Health will do is they will find similar patients that have been in that same situation, maybe over the last 20 years in their kind of electronic health record data that they have access to, and then surface insights to you. Say, well, you know what? We have 100 similar cases that we've seen in the last 10 years, and this is how they did. And that can be a lot more valuable than trying to apply, a guideline or a clinical trial to your specific patient case. Next slide. Okay, and then I'll end on this top left quadrant. Next. So again, this is clinical applications of AI that are actually directly interacting with the patient. So this I would say is the highest risk category. So the first company to highlight is Hippocratic AI. And what they're essentially building is a virtual nurse. And so they're trying to not replace the physical things that a nurse does. They're trying to replace the virtual things a nurse does. A lot of you might know health systems use nurses to call patients a lot, right? So a nurse might call a patient to do a pre-operative checklist the day before surgery. They might call a patient to do a post-discharge checklist the day after they were discharged from the hospital, to make sure that they picked up their meds and got their follow-up appointment, et cetera. A lot of these kind of checklist-driven or protocol-driven things, why can't we just give that to an AI agent that can then just talk to the patient and collect that information? So that's the idea there. And then next. And then the last company I want to highlight is UpDoc, which, full disclosure, I'm a co-founder in. What UpDoc is trying to do is we're trying to help expand access to care for chronic conditions like diabetes. And how do we do that? By having a doctor or a pharmacist prescribe an AI assistant to a patient to help a patient manage their medications. And so that kind of helps provide kind of high-touch care to patients who need it without them having to come back and forth to the doctor's office very frequently, which is sometimes needed for patients that are on insulin or on a lot of diabetes medications. So I hope that was kind of a crash course, very quick overview of the space. The key kind of couple of takeaways are that though there's a ton of companies, the vast majority of them are pretty early stage, and they're doing pilots with health systems. They maybe have a few health system customers, but they haven't established strong footholds yet. That's really where we are. So the overall space is still pretty immature. And then when you think of low risk versus high risk, you're going to see a lot more low risk things out there in general, just because it's easier to kind of push out a half-baked product if it's low risk and then iterate on it based on feedback, versus things in this top left category. It's going to be a while before you see products like that are truly implemented in care, because they have a much higher bar they have to pass.
Well, terrific. Thanks, Ashwin. That was a really awesome overview of the landscape of the AI companies in healthcare. I wanted to take the next 10 minutes to walk all of you through some of my own personal thoughts on the role of AI in compassionate care. Can we make medicine more compassionate through AI? So to give you an overview of my remarks, which I just want to emphasize that these are my personal thoughts, and they're evolving, and hopefully at the end we'll have an opportunity for more Q&A and dialogue with other panelists and their views on this. But in terms of the overview, I want to start by outlining the ways in which healthcare currently falls short in terms of humanism and compassion, and then discuss my thoughts on how AI may transform this in the near term, both for patients and for providers. And then close by talking about ways to incentivize the development of AI tools to foster greater humanism in medicine. Next slide. So I think we've all been patients, and we all know patients, and we have been through the healthcare system in ways that have left us wanting more in terms of compassion and humanism. What are some of the ways in which medicine currently falls short there? One, as you all are aware, medicine has high aspirations, but as practiced in the modern arena, it is very much a competitive business, very competitive, and focused on efficiency and profit. Many of us as patients have, I think, felt that clinic visits can be short, not enough time for patients to voice their concerns or to be heard authentically, not enough time for clinicians to educate their patients or develop a trusting relationship. Ashwin and I believe Karl as well have touched on the kind of administrative burden of modern healthcare, right? Medical billing can be overwhelming, very complex. Clinicians can spend far too much time doing paperwork and appeals and not enough time interacting directly with their patients. And patients, unfortunately, can be left with surprise bills and can be left on call waiting, dealing with these kinds of issues. Next slide. There are also widespread disparities in access that have been highlighted time and time again. And we're seeing that the high cost of healthcare in the US unfortunately has an impact on reducing access to those who need it most. And more than just the cost, there's also inequities in distribution of access. So many parts of the country where there may not be enough clinics or clinicians to be available for patients who need it. And this can be a challenge. Another aspect to humanism and compassionate medicine is the fact that health systems and physicians focus a lot of their attention on treating diseases, but perhaps not enough attention on treating people. So we have been shifting in the US from a fee-for-service kind of environment towards capitated care and value-based contracts. But even those kinds of novel ways of assessing patients and treating them do largely focus on metrics, things that we can measure easily, like A1C for diabetes management or blood pressures, but not as much on how patients feel, patient satisfaction about the visit. Generally speaking, we do treat what we can measure and what pays the bills, but we may not be treating things in a more holistic and comprehensive way. Next slide. So how does AI fit into healthcare? As I think Ashwin has made kind of very clear, there are a lot of the innovation that's happening in AI right now is really coming from industry, coming from the private sector. Some of ideas that are foundational to this whole field have come out of academia, but I think a lot of the development and then deployments that are evolving as we speak are really coming out of a very competitive sector. And so by the very consequence of that, profit is really driving innovation. So companies are developing AI that they think their customers, i.e. insurers, hospitals, clinics largely, want to buy, because presumably this is technology that will help them save more than the cost of the AI that they're investing in. Next slide. So taking all these thoughts and translating it into the question of how AI is likely to impact humanism and compassion in the near term, I want to outline my thoughts by touching on 2 points. One, the patient perspective, and the second being the healthcare provider perspective. So starting with the former, I think as a lot of people are already seeing, and we're going to see a lot more of, AI almost certainly is going to improve diagnosis and treatment across diseases. So the ability to deeply mine data from medical records and publicly available sources of medical knowledge, it's almost certain that AI will have positive impacts in terms of reducing diagnostic delays and errors, in maybe even going beyond data that we're collecting as part of routine care. For example, ways to collect a lot more and diverse kinds of data directly from patients via kind of surveys and wearables, et cetera. It's likely that AI is going to have a big role to play in terms of personalizing treatment and achieving this long desired but distant goal, you could say, of personalized and precision medicine. There's a lot of active development in the space of AI as it could impact mental health. As you all know, we're living through a new kind of crisis of loneliness in the US, as the Surgeon General has pointed out. And it's likely that these AI chatbots that could have infinite patience and infinite capacity to attend to people's needs could have a large role to play in dealing with these mental health issues. AI has, I think, a role to play in terms of optimizing patient compliance. So educating patients on their condition and proper use of treatments, reducing gaps, even with patients who may suffer from language barriers now in the advent of high quality translation services and even audio to deal with patients who may not have the same level of technological literacy. There are potential impacts that we may see on disparities. So as AI makes healthcare delivery more efficient and lower cost, this could potentially lead to some downstream consequences that would make healthcare more affordable and more accessible to many folks, particularly those who don't have the same socioeconomic means. And while, as Karl pointed out, AI can be susceptible to bias, there is an upside to that, which is that AI can also be trained to have less bias than humans, who in some ways could be harder to kind of educate or harder to remove biases once they're baked in. So I think there is an upside to the question of the role of bias in AI. Next slide, please. There's another aspect of this, which is AI going to offload a lot of the administrative burden and therefore allow patients to spend more time with their clinicians? There are differing views on this point, and where I come out on it, at least at this time, is that I don't think it's likely that there is going to be a lot more time between physicians, let's say, and patients. And part of the reason why, as I said, is we have to recognize that we're operating in the context of medicine as a business. And AI as fundamentally a tool that can help save time will probably lead to MDs and other clinicians spending their time elsewhere, wherever the profit motive drives them. So this, I think, is potentially a missed opportunity, but this is what I see. There is another side to it, which is getting at the point I brought out before about AI having a lot of time, you could say infinite time. So AI can be very patient, can be trained to sympathize, and potentially could fill some gaps with respect to the desire for connection that perhaps patients may be wanting from their physicians. So I think AI probably is going to be offered as a substitute for this face-to-face time. But there are, of course, some fundamental limits. AI can be trained to be sympathetic, but can it be trained to be empathetic? Perhaps not, in the absence of an authentic and lived experience. And I think this is potentially a loss that we may see going forward. Next slide, please. Yes, so speaking to administrative burden, I think, as Ashwin pointed out, there are lots of startups that are really targeted at this point. And I think it's likely to have a positive impact. But there needs to be a clear value proposition in terms of the people who are going to be paying to reduce administrative burden. So long as that value prop does exist, I think we're going to see a lot of positive developments here. And to the extent that perhaps market incentives don't exist, there's also a definite and important role for the government to incentivize this much desired kind of unmet need. And then moving to this last point here about measuring patient satisfaction. So we've talked about patient satisfaction perhaps not being high for a variety of reasons. But if AI can improve the capture of data from patients, then this could be a new metric that health systems can strive to improve upon. And so so long as incentives are there, I think this could be another way in which AI could help. Next slide. From a worker standpoint, I think, unfortunately, it's likely that AI will eliminate some jobs in healthcare. It'll happen kind of gradually, and it depends on the rate at which things progress. And to kind of borrow from Ashwin's analogy, starting with the low-risk activities, the things that aren't patient-facing and are of lower consequence, you could say, and then gradually ratcheting up. But this is what I foresee. Right now, AI is, really just embedded in the context of software, right? So I think the kinds of things that AI can replace are going to be largely cognitive and repetitive in nature, but less kind of physical, and embedded in the real world along the lines of surgery or procedural kinds of ways in which, it could intervene, if you will. I don't know how much of an impact it'll have on reducing clinician workload or burnout, because as I was saying before, I think we're going to replace one with the other. The extent to which we reduce time that clinicians spend after hours writing MyChart messages, that time I'm sure is going to be redirected to other activities that ultimately will lead to profits for the health system. So this is what I think. Next slide. So I think this is the last point that I want to bring up, but I think an important one, which is what can we do to incentivize AI that creates more humanism? My perspective, at least for now, and I would love to hear the panelists, their views on this, is that I think it's going to be difficult. And again, my perspective is largely colored by kind of, I guess you could say, an economics point of view. But a lot of U.S. healthcare is paid for by employers and by the government, right? Not by individual consumers of healthcare. If we paid for healthcare, then I think we would flock to systems that would provide excellent and compassionate care. But insofar as we're stuck in a little bit of a kind of principal agent problem, you could say, I think that creates some inefficiencies and some missed opportunities. And so to the extent that companies follow the money and create solutions that help providers, I think that's where we're going to see things move. Next slide. This is the last point, which is that insurer coverage decisions are largely driven by laws, market forces, norms, and evidence of cost effectiveness. But right now, humanism and compassion are not really a part of this equation. And I think for that reason, if not others, there is an important role, in my view, for the government to make this a priority. So, for example, if CMS revises its reimbursement policies to prioritize humanism, then I think provider behavior is going to change, systems will change, and other payers will follow. So the extent to which all of us can advocate for governmental policies that really make this a priority, I think that will be something that we can all do to help AI be foster more humanism in medicine. So with that, I'll turn it over to Michael.
Let's see. Thanks very much, Vivek. That was an excellent overview. What I want to do now is talk a little bit about how AI, as we've been talking about, actually becomes a product and show you an example of some of the challenges. If we go to the next slide. I mean, we've heard a lot about AI and AI that, will be products, but there's a big difference between will be and are, and a big difference between in development and, hopefully come to patients at some point, and what actually does. Last year, there were about 1,000 medical digital startups, and that's the ones we know about. I know 50 at UCSF itself, at least ideas, that really probably will never make it to the bedside. So there's a lot of good ideas out there. There's a lot of potential for innovation, but as Vivek pointed out, the economic incentives are what drive AI product development. And unless there's going to be a strong revenue stream, these things just won't make it to the clinical environment. I mean, for example, um, uh, Ashwin pointed out a couple companies, Cohere and Ambience Health, and both of those had been around long before the era of large language models. And in fact, each of them has raised, about $100 million in investment. And those investors are going to want to get paid back 10 times the money at least. So you're talking about at least $1 billion of revenue that will drive those companies to stay in business. And I think that leads to the question of, okay, it's going to it takes years for any given idea to make it to market. And where will these ideas come from? I mean, Vivek mentioned academia, or early stage entrepreneurs, or these large legacy players like Epic and the like. And I want to say a few words about that. Next slide. The next slide. So about a year and a half ago, I joined forces with Karl and some other physicians, data scientists, and really our goal was actually not to start a company, we called it Project Quench at the time, but try to address this issue of physician burnout. All of us who are involved in one way or another with clinical medicine know about this physician burnout problem. It may be the most important problem we have right now in care delivery, is physician burnout. And so we did a survey and we looked through, talked about 75 physicians and other providers as to what the biggest causes of burnout were in their practice. And it turns out inbox management, it's my chart in the Epic situation, was the one that the vast majority of them wanted to have addressed. And so next slide. We started our Project Quench, and we thought, well, this has a lot of potential to actually be a product in the market. And the docs we talked to and showed this to loved it. And so we designed this thing we called Inbox Manager. For any of you who have ever seen the MyChart interface, we created an interface which is much nicer, much more functional than what is out there. And this was in April 2023. And we were about to actually launch this, and a lot of us had spent a lot of time putting this together. Next slide. But around the same time, Epic announced that GPT-4 and OpenAI and Microsoft were now going to be merged with Epic to design to integrate AI in medical record use. And this announcement alone crushed probably hundreds of startups that were attempting to innovate AI into the healthcare environment, including Project Quench. Now, Epic and AI and OpenAI didn't really have a product yet, but they were announcing that they were going to have a product. And quite frankly, they still don't have any product. But as I say, the big legacy players can suppress the innovation that happens in academia or in startup companies quite effectively, which is probably why they made the announcement when they did. Next slide. We talked a little bit about kind of the economics of companies, but there's also an economic structure in place in health systems. Notice that we don't have any chief information officers or chief technical officers on this panel. But when you survey CIOs and you ask them, what factors are you going to consider for AI and clinical decision support in purchasing these actual products, to be deployed at large scale? And the first and most important is existing vendor relationships and contracts. So, Epic, typically healthcare systems have a $50 to $100 million a year contract with Epic. And so if Epic says we're going to have, this great AI, then that's where the CIOs are going to go first. Even more important than financial considerations, because there's just less hassle to go with a given vendor. interoperability, regulatory compliance, and way down on the list, unfortunately, is provider requests and burnout. So you have a situation where the economic buyer, namely the health systems, and the user, namely the physicians, nurses, et cetera, and even the patient, are very different and therefore not considered as the highest priority. And then AI safety, which all of us talk about as a high priority, the CIOs sort of assume it's taken care of someplace else and don't consistently consider that a high priority. Next slide. Fortunately, we looked around and we had designed this great product to do medical record analysis. And we said, well, where else in the healthcare system does medical record review happen, where it's a great burden, aside from point of care, which was Project Quench's initial attempt. And what we found was that there's a lot of physicians, nurses who need to do workers' compensation review, medical legal analysis, and what they get is 1,000 pages of PDF documents and need to go through those PDF literally page by page. And so what we basically did is, next slide, is took, is we said, like, this is the state of art right now for medical record review in these settings like medical legal or utilization review, many thousands of pages of PDF, 5 to 10 hours worth of time to review those things. And we said, well, maybe AI can do this. Next slide. And sure enough, we've developed this system for ingesting PDF, large healthcare records up to 10,000 pages as PDFs, run them through the AI, and we're able to produce chronologies, table of contents, even a chat interface so that a physician or nurse can actually talk to the medical record and ask questions about utilization or injury and that sort of thing. Next slide. Again, one thing to talk a little bit about is what is the role of our health systems versus our scientists and physicians. And as I mentioned, Epic announced this integration. This is from the first, it's back in August of 2023. AI is going to revolutionize clinical documentation, and Emory in Georgia were starting to do this, and Epic, here's another announcement. And then on the right, what you can see something is very interesting, which is Epic is going all in on generative AI in healthcare. Here's why health systems are eager to test drive. So providers are concerned about AI in safety and bias, and we form committees and we write policy papers and we urge caution. And yet the institutions themselves, the same institutions where the researchers and the academics may be warning about the risks, those same institutions are charging ahead to buy these untested, opaque AI systems from these large corporations just because they're established vendors, and the CIOs think, this is where the next wave is going to come from. So I do think there's a misalignment between faculty and researchers, such as all of us on this call, and what health system leaderships who are responsible for the purchasing decisions actually do. Next slide. Some ideas. I think we've all shown you some ideas on how to solve some of these problems. And, one of the things that that health systems can do, even without government, is say that, or with CMS's encouragement, is to say that a health system that has revenue of over $1 billion per year needs to test at least 4 pilots a year of AI that's specifically designed by physicians or entrepreneurs that can be put into play as an alternative to whatever Epic or Cerner comes out with. Easily doable. The motivations are not there. The financial incentives are not there. Perhaps they could be put into place. When the EHR system started, Epic and Cerner and the like, and that was in the high-tech law, there was $30 billion put in there in that law to basically convince physicians and hospitals to buy these EHR systems. And of course, they bought them all from Epic. And so I think it makes sense that money should be made available, like the 30 million that was made available to Epic, for non-legacy companies, again, small companies, entrepreneurial driven, academic driven, to develop these commercial applications of AR. One other thing we didn't talk about is data. You know, large language models need a lot of data to train. So where's that data supposed to come from? And we know that health systems have been very reluctant to let their data move out of the silos that they're in. A lot of it is because of HIPAA and identification. However, the de-identification of clinical data has been revolutionized in the last few years by AI language models. And so it's not hard to de-identify the clinical data set, make it, HIPAA compliant, and then make those data sets available to any company. That way we can train on non-biased data. So anyway, I think I'll stop there, and thank you all very much for your attention.
Well, thank you all for an incredible panel. Why doesn't maybe our panelists can come back on screen, and we'll start to answer some questions for us. It's really, really, really interesting. I feel like I have much better handle on some of the things that are happening, but it's such a complex, overwhelming, and quickly evolving field. So like myself, there are many people who are wanting to ask questions. So a question from Karen, who's an experienced critical care nurse. This is a question about expertise and experience. How does that make its way into decision-making and, any predictive models that AI might facilitate in clinical care? It's a great, great question. What do you think?
I'm happy to dive in to this, but would welcome other panelists' perspectives on it. It's a great point, and I've relied on critical care nurse gestalt many times at the bedside. So thank you for that gestalt. And in no way currently, at least, do I think that AI will have the same level of gestalt, but in general, the way, and I didn't dive too deep into how AI models work just because there was so much to talk about, but AI models are very, very good at picking up on subtle patterns. And in fact, oftentimes patterns that are completely invisible to our eye, which is kind of akin to any of our senses, eyes, ears, whatever. And that's pretty akin to this clinical gestalt that we talk about, like not necessarily seeing like a data value that's like, oh, wow, the lactate's super high, I better be reactive, but this proactive response, I don't want to say like bullish or like that I think that this will happen, but I would not be surprised if an AI could predict things before they happen. And in fact, that's kind of like their whole shtick.
Creating predictive models.
Yeah. Just to add to that, I totally agree, Karl. I think probably what AI models learn is their own version kind of this like clinical gestalt, clinical intuition. There's probably some level of overlap of what that is and what a human's intuition is. How much overlap kind of remains to be seen. So I think like my short-term prediction of these diagnosis aids, they'll act more like co-pilots. They're not going to ever replace the diagnostic abilities of a clinician, but they might be something that kind of is running in the background and kind of surfacing up suggestions like, hey, did you think of this? Or, hey, the risk of deterioration of this patient seems high based on X, Y, and Z. Use this to kind of inform your global decision-making. That kind of thing. The other aspect that I'll add is as these models get more advanced and incorporate kind of additional senses, right? We're just talking about language models, but you could, there's vision models too, right? You give vision to an AI model that can actually see the patient, maybe with a camera in the room. That can add another layer, right, of this kind of intuition or gestalt.
That's amazing. I don't know whether to be encouraged or not. Vivek, did you want to think?
I just wanted to toss in one more real world thing is that, these are all great. and the nurses and the doctors have lots of stuff in their heads, and it's unfortunate that many of the companies who are developing these products don't actually talk to doctors and nurses. So these things are designed by engineers and business people and not the primary care users. And I think that's been a problem for the last 20 years and is actually part of why we have such burnout is the companies keep providing us with a solution for the problems that they created. And so I'm hoping in this new round of AI that we have more people like Ashwin and Vivek actually designing the products rather than a couple of engineers in Madison, Wisconsin.
No, that'd be so great. Is it okay if I go to some of the other questions? We have so many really cool questions. There are a couple of two questions that are sort of revolving around the same thing. Just because we can do it, doesn't mean we should do it. And there's two questions about AI-powered agents or robots or whatever, particularly in call centers, which in the words of one person in the, I guess that's a Q&A, says it leaves me begging for a human. I have to say, I just had that experience today. So what do we do with that? It leaves me wanting human connection. What can we do to mitigate that?
I mean, I'll just throw something in. What can we do and what will we do? Karl can speak more about this, but one of the things about large language models is they can learn. So, you could actually design a system where when you talk to the chatbot and you're not happy with the response, you tell it what you're not happy with, and you get a million of those things back and forth, and then Karl fine-tunes his large language model to fix those problems. So the technology to do that is available. We'll see how long it takes to actually, bring that to market. Karl, what do you think?
Yeah, I'll be brief and pass it over to Vivek and Ashwin next. But yeah, in general, I think it's certainly possible to improve how these models work, especially like the QA, right, over the phone. Probably that system is not running some of the newer technology, and it's like an old rule-based, like select 0 for this, which is just not how things will be going forward. And if you're curious on like how I think the future will look for especially like these audio types of encounters, is the GPT-4 Omni, which was super impressive to me from OpenAI, and it has a very low latency and a pretty solid grasp on like semantic meaning, which means you don't have to hit the exact target words that are in the rule-based scripts of yesterday's technology. You can just say, what you're thinking, and it will largely understand. So definitely go give a try. I don't work for OpenAI, but it's a great model. Try it out.
I want to ask a couple of more questions from the Q&A because they're really, really, really great. There's a lot of concern about having the wrong people generating solutions for the bottom line rather than from real clinical need or anything that's really going to benefit from patients. And I heard you say, well, we need government to step in and regulations and so forth. But honestly, what can the average person, trying to get along in the world, what can we do, to advocate for the needs, not just of all who work with patients, but the patients themselves?
I mean, I think the government is going to take decades, and with AI moving so quick, it's not even worth thinking about. I think it's at the level of the health systems, and it's the CIOs and CTOs of the health systems. And, I mean, there are committees that probably Vivek and Ashwin are on for like AI and data sharing and stuff. And the CIOs don't go to those meetings. They don't listen. So I think really it's at the level, that's at the level. It's either the presidents of the health systems or the next level down, the financial people, the technical people. They have choices and they can pick technologies that are more compassionate. So we don't need a government mandate for that because it's going to be nice to have. It's going to take too long. But I do think health system leaders, not physician leaders, because they have their view and it's a good view, but health system administrative leaders, that's where I think the pressure needs to be put.
Yeah, but it's going to take all the people on the ground treating patients to put the pressure on those people who are making the decisions. And that I think
It-
that can be overwhelming, but it can also be very empowering. No?
Well, health systems are a hierarchy, right? So you have the physicians, and then there's the department chairmen, and then there's the deans, and however you structure it. So, I think if you wanted to lobby somebody, if you work in a health system, that's
Yeah.
who I would lobby.
Yeah.
And you can do that today. You can send an email to your CIO saying, "What innovative AI solutions are you buying other than from OpenAI?"
Yeah,
You
yeah.
know,
Yeah.
But
Well, I want people to leave here feeling empowered. Unfortunately, we have to end the webinar, which is too bad because we have so many more great questions in the chat, which I regret not being able to address right now. But perhaps we can, if you all wanted to post some responses, we can post those when we post the webinar to our website. Julie, why don't you close us out? Thank you so much to all of you and to everybody who's been listening. It's been incredibly interesting. Okay.
Fantastic conversation. Thanks so much to our panelists and to all of you who have joined us here today. We hope you enjoyed this Compassion in Action webinar. Please keep an eye on your email for news of future events. And finally, please take a moment to fill out the very brief survey we'll be sending you after the webinar. We appreciate all of your feedback on today's session. And thank you for joining us and for your commitment to compassionate healthcare. Take care, and we hope to see you soon.
Thank you all.
Thanks, everyone.